We're now going to turn our focus to cancer of the uterus. This disease is also referred to as endometrial cancer. The lining of the uterus is called the endometrium, the most common of all the gynecological cancers. It is, however, increased in 50% in the last 10 years. There are significant lifestyle risks associated with this cancer. ANZCOG has a strong research focus on endometrial cancer, including an ANZCOG clinical trial to evaluate the benefits of exercise on women who have been diagnosed. Dr. Di Adams is our next speaker. She's a medical oncologist with a specific interest in survivorship care. She is a member of the Clinical Oncology Society of Australia Exercise Committee that has released the position statement last year calling for exercise to be part of routine cancer care. She's coming to talk to you. Please welcome her.
Thank you very much for allowing me to speak today. Yes, I'm going to take my luck with the clicker because it was causing a few issues earlier. Right. So I'm going to talk about obesity and exercise in gynecological cancer outcomes, so a complete change of tack. Move over tobacco. Obesity is on its way to replacing tobacco as the #1 preventable, modifiable risk factor for the cause of cancer. And endometrial cancer is the leading type. So this is way beyond colorectal breast cancer down at the bottom, gallbladder, kidney, pancreatic cancer, adenocarcinoma of the esophagus, and endometrial cancer is at the top. So bowel cancer's got a sign saying, does obesity really cause cancer? So yes, obesity can cause cancer. Not everybody who is obese who has developed cancer because they are obese. It's really important to understand that. But if you are a woman and you still have a womb and carry extra weight, you and your doctor need to think about how to reduce your risk of endometrial cancer. Important, the doctors involved. They need to help. Because we actually know the higher the BMI, the greater the risk. The greater the risk of developing it, and once you've developed it, the higher the BMI, the more aggressive the cancer is in terms of actually likely that it's going to kill you. So it's really important we think about how to improve risk and reduce BMI. And in America, they actually have published that the lack of exercise and being overweight can lead to endometrial cancer. 3 out of 5 women have developed that cancer because they have carried extra weight and have not taken as much exercise as perhaps we had recommended. So in Australia, there are 1,800 women diagnosed who perhaps, if they had not carried extra weight and had taken more exercise, could have been prevented. But is that message being given to women? So as you can see, the bowel cancer poster showed to lose weight, but are we actually advocating that to our women who carry extra weight? And in just over 20 years, obesity rates are up and uterine cancer incidence has risen by 20%. And the concerning part is that the high obesity rates are actually developing at a younger age. So we're actually seeing younger women diagnosed with endometrial cancer. So 35% of young women are obese. And so if you ask any of the gynae-oncology surgeons that are operating, they are seeing younger women. This is not genetically related. This is not Lynch syndrome. This is because they have carried extra weight and no one has discussed with them the risk that they carry as a result of the extra weight. So about 5 years ago, I actually spoke at ANZCOG about this concept of an endometrial tsunami. So there is a current wave of women diagnosed with endometrial cancer, but I think there will be a bigger wave of obese young women who now are exposed to the risk of endometrial cancer, and we need to get that message out. So I think the average age of endometrial cancer at diagnosis is going to drop. We haven't yet seen it, but that's what's being reported by a lot of our colleagues. I'm now going to talk about not all fat is created equal. It goes back to the old apple and pear. And we actually know that in the apple figure, that is where you actually carry fat centrally, and that's called visceral fat. And that is not as friendly as old subcutaneous fat around your rear end and just on the skin. And that's a problem because central fat is a metabolically active organ. It's a shame it's the only metabolically active part of one, but but that's the concern, because metabolically active fat is bad when it comes from your central abdomen. For the same reason that it drives cancer, hypertension, insulin resistance, and type 2 diabetes, the same process of inflammation can drive cancer. Sorry, that's a guy, but I actually couldn't find a little figure of a lady, so I do realise that. But we know that this inflammation plus estrogen, and we do have higher levels of estrogen. If you have more fat, you aromatize your fat into estrogen, plus insulin, plus equals this obesity-driven cancer. So what's the impact of having obesity and being a survivor? Well, it can affect your quality of life, and it can add to the morbidity of the cancer treatment. If you're a young woman and you haven't yet had your kids, it can affect your life in a major way, because it might affect your fertility and ability to have children. And actually, Anscog's got an excellent study which is looking to see whether they can reverse early endometrial cancer changes, and it's called the FEM study. So Anscog is already looking at that. It may impair the delivery or the benefit of therapy. So 10% of women who are actually what we would describe as morbidly obese can't actually have any therapy at all because of their end organ damage from diabetes or heart disease. And we've actually seen that it can actually increase the recurrence or aggressiveness of some cancers, not just this old-fashioned type 1 endometrial cancer, it's actually type 2 endometrial cancer, which was a new find for us. So we are concerned it's actually promoting the aggressiveness of the cancer. But the big thing is that actually the cardiovascular disease is the leading cause of death amongst survivors of endometrial cancer. And is that message actually getting out? So we know that when a patient is diagnosed with cancer, the majority of people are actually entering into a cancer diagnosis insufficiently active. We then find that the majority are actually experiencing declines in physical activity levels during treatment. It's fairly obvious because what you go through, it makes you exhausted and you don't really want to necessarily exercise. And then a lot of people actually never regain their pre-cancer physical activity levels, which were not actually that high to start with. So how do we change this paradigm? This is where exercise comes in. We know that exercise is one of the best medicines you can take beside your cancer treatments. And one person has actually described it as the missing link between cancer treatment and living a well life. So I would actually advocate that exercise should be a core part of routine gynecological cancer care. So just like your surgery, your chemo, your radiation, exercise should be in there. And that's what we are calling for as a community, particularly from the COSA, which is the Clinical Oncology Society of Australia. Because, and this is famously described by Prue Cormie, who's the lead, if it was a pill, we'd all take it. Yes. It improves our energy levels, it reduces fatigue from cancer and its treatment. It improves the ability to tolerate cancer treatments and receive the full dose. We actually know you can get more dose in if you exercise. It actually maintains and increases muscle mass, it reduces fat mass, and it improves this sort of healthy muscle to fat ratio. It improves your physical fitness, cardiorespiratory endurance. It improves stress levels. And they're all pretty high when you're going through treatment. And it potentially will improve your survival. So we know potentially in breast cancer, bowel cancer, and these are all sort of epidemiological studies looking at many, many thousands of people, but also looking at trials going on, that it can actually improve your survival. And so there is the ECHO study, which is also looking at that as a secondary endpoint. It can improve your quality of life, and it can lessen the impairments on the function that the treatment has caused. And the most important part is it's actually safe during and after treatment. It's really important because a lot of people go, oh, I don't know whether I could do this because I don't know if it's safe. You know, is my doctor going to allow it? So I'm going to dispel that myth. Exercise isn't a pill, so it's less likely to be funded by the drug industry. They don't get any kickback for this. So unfortunately, all those millions of dollars that very kindly they fund for many, many pharma studies and all these development of new drugs, unfortunately, exercise does not get that funding. So it does rely on trial groups like Anscog. So this is an example of an Anscog-funded study to look at exercise. I'm not sure how many people might have participated in the ECHO study. Does anybody participate in this study? It's for ovarian cancer. It's tracking very well. and it's looking at the effect of exercise during chemotherapy on the physical well-being for patients on first-line treatment of ovarian cancer. So, exercise as a treatment. What does it do? It maintains and increases muscle mass. Why is that good for us? Because it can prevent falls and fractures. So who feels more like the bird on the left? So the problem is that a lot of our chemotherapy drugs that we use in gynecological cancer can actually affect our nerve endings and give us balance problems. So taxanes and cisplatins can cause neuropathies. And what's really important, and I've just included a few articles, a few trials. This is a paper from a few years ago talking about the falls, functioning and disability among women with persisting symptoms of chemotherapy-induced peripheral neuropathy. That's the tingling you might experience. But actually the bigger picture is what happens if you've had that and it's persisting, is what happens to your balance and risk of falls in the future. And actually if you exercise and you maintain your core strength, you are less likely to fall over. So it's that shut your eyes and are you going to wobble and fall over? You've lost your balance because of the chemotherapy, and if you actually exercise and you improve your core balance, that potentially would reduce that risk. So we know that rehab focused on strength and balance training is known to prevent disability and falls in older people and in people with neurological conditions, so we should be including it in our cancer care plans. What about cancer as a treatment that maintains and increases muscle mass? How can that help your immune system? So everyone's talking about immune therapy. Well, we actually have our own immune system that we can mobilize through exercise. So they're called natural killer cells. They're natural born killer cells. They are our first responders, and they go out and they seek infection, they seek out cancers, and they're actually now looking at trying to improve natural killer responses. Just like these things called CAR T cells, they're trying to do the same things with natural killer cells, but we actually know that exercise can make natural killer cells respond better. So if you exercise, you make your natural killer cells work harder. What about exercise as a treatment to counteract weight gain? Treatment-induced menopause. Oh, that's a scary thing, menopause. I'm beginning to experience it, and it's not much fun. So all those kilos, so exercise can help counteract that. The steroids we give to counteract some of the side effects of chemotherapy, dexamethasone, and also the development of this syndrome, it's called the metabolic syndrome, where you get insulin resistance and chronic inflammation, and it's that going back in that chicken and egg and sort of stimulating cancer cells. I would like to say that exercise can be fun. The dragon boaters are the best example of this. Heather's a wonderful other example of how exercise. She can go to Kilimanjaro and run up hills and you can enjoy yourself. So it's not meant to be boring exercise. You've got to pick something that you want to enjoy. And the dragon boaters are a great example. It's a source of social support during and after the course of treatment. You can build and maintain relationships at the time of your cancer, and it might actually help you deal with the effects, how the effects of cancer are dealt with. It's like a problem shared. Do you need permission from your oncologist or surgeon for exercising? No, but it could assist with communication. Should your doctors be discussing exercise with you? Yes. The Cancer Institute is telling us that we need to discuss exercise with our cancer patients. So they are evidence-based, and they are telling us to do it. Are we doing enough of it? I wrote an article 3 years ago. No, I think we need to do more. But are we talking about it enough amongst our patients? So that's why we came out with a position statement last year from COSA, which calls for all members of the multidisciplinary cancer team to promote physical activity and recommend that people with cancer adhere to exercise guidelines. So that's nurses, clinical psychologists, your occupational therapist, everybody. It's not just the doctor's job, although the doctor should be recommending it. It is everybody's responsibility to be recommending exercise. But we know there are barriers. If you've had abdominal surgery, it's like, well, what can I do safely without potentially having those wounds undo? What about how I feel, being a bit constipated on treatment, or I'm going to get diarrhea, I don't want to go to the gym, just in case it's a very difficult thing to deal with all of a sudden. What's my pelvic floor doing? And also, how do I deal with a PICC or a portacath? So, here I am telling you to take exercise, and you're saying, like, when hell freezes over. So how can I get you to embrace this, and how do we do it? Well, we have to get the right person. Not everyone has experience in exercise for people with cancer or gynecological cancer. do not go to your local gym trainer who does not know anything about cancer and also does not necessarily know anything about gynecological cancer. You need a person who understands what you have been through. You need to go to an ESSA accredited exercise physiologist or physio who can build your confidence to feel safe and comfortable doing exercise. You can go to the gym trainers afterwards once you've got your plan and you're safe. Do not go to them first. It's really important because ESSA accredited exercise physiologists and physios have actually gone through university of how to prescribe exercise to people with chronic diseases. And unfortunately at the moment, not all of them are based in hospitals. The exercise is prescribed like a medicine. They tailor the outcome. Are you trying to prevent fatigue or are you trying to build up muscle mass? And they individualize it, just like a certain medicine that you're taking. So the type, the intensity, and the volume, it's really important that it is tailored to you. The intensity might be how intense the aerobic side is, and the resistance could be how many weights or repetitions you're doing. And interestingly, we actually know that all people respond to exercise, but actually those with the worst symptoms and the highest level of fatigues are the people who benefit the most. So questions for your exercise professionals. How long would it be before I start to see some benefits from the exercise program? How many appointments are we going to need and how much will it cost? Well, how much does it cost? So there are benefits through Medicare. Medicare can pay $5 per year, and health funds can also pay for exercise physiologists. You should also flip it around and think about this as an investment for your physical and mental well-being and to manage any other chronic diseases you might be experiencing. So some people describe it as my health insurance policy, particularly if you're going to face treatment again in the future. You'll be fitter as a result if you have to face treatment in the future. The most effective approach is to be supervised by an exercise physiologist or physio. Should be convenient if possible. And ideally in a cancer-specific group, a shared experience of cancer is noted to help a lot of people. So these are examples around Australia. So you've got the YMCA and YWCA up in Queensland. You've got the Enrich program in New South Wales. You've got XMed in Victoria. And there are programs all the way around Australia similar where you can go into exercise programs. This is my program I run down in our cancer centre with our exercise physiologists. It's called Active Survivor. I just have one more comment, which you might go to the gym, but if you sit on your bum for 12 hours a day, what are you doing to your risk? I think that meerkat's pregnant, but I had to find out. I wrote fat meerkat and it says... So if you sit after your cancer diagnosis of bowel cancer, you actually carry a 62% higher risk of dying from your cancer. We haven't seen these studies with endometrial cancer or any other gynecological cancer, but it's a worry given the fact I've just said there are some similarities. So I would just like to say that I may have been preaching to the converted. Sorry, Heather. But all I wanted to say is exercise is safe if you have had cancer, but you need the right person or people to help you. Thank you.
Okay, questions. Do we have any questions to Dr. Adams? Yes?
Do you think that message is getting across? Because I was diagnosed with ovarian 2 years ago. And I was quite active at the gym at my time of diagnosis, and I was actually told to stop going to the gym due to immunocompromise.
Yes. Yeah.
And even these days, like even my oncologist has this time I'm allowed to go to the gym. That was nice, the last round of chemo. But I think, that message still isn't getting out there enough. So have you got some ways of trying to spread that message?
So COSA is planning to implement the exercise position statement this year, where there is a committee to actually try to implement exercise whereby all cancer centres and oncologists and surgeons will understand the benefits and how to actually apply this. The question of the gym is an issue, and we just say, look, you have to have good hand hygiene because obviously you don't want to contract something But it shouldn't be that you can't attend a gym. And then I guess the other thing is whether you attend a group session with other cancer patients where they are also more aware. But yeah, you have to wash your hands after training. You have to make sure that everything's clean, so you're not exposed. But no, unfortunately, we would be recommending counter to what you've been advised. However, all the exercise you did beforehand will have set you in good stead.
It's all right, I go to the gym.
Yeah.
That's really interesting about the Medicare rebate access. So do people, can they get that, can people get that through their oncologist, or they need to go to their GP?
No,
What's the process?
Through a GP. So
Through the
it's
GP?
from it's primary healthcare
Yes.
plan.
Okay.
It used to be called an EPC. It's got
Yep.
a very long name now. So long as you're not getting your toes done,
Yes.
or you're seeing a psychologist on the same plan, because
Yes.
you're only allowed 5 per year for any sort of particular allied health. And so you do have to pick what's the priority for you. But you know, it is there, but we can't provide it as oncologists, as specialists. It has to come via the GP.
So just to clarify then, that's the same plan that would cover a psychologist. So if you've got a psychologist referral, you can't do that. And if you are approved, is it done in a public hospital? Or is it?
So there are hybrid models. So there are
Yep.
some. I'm quite unique where I work, where we have an exercise physiologist that works in our
Yeah.
centre. Lifehouse also has an exercise physiologist, but no, it's something that we're also calling for, is to get exercise physiologists within hospitals where possible. So this isn't just something that's in community, although in the majority of people, we're trying to actually encourage people to participate in community and not necessarily have to come back to hospital, because not everybody can come back. There's geographic distance, and the other role is whether we can do it through telehealth.
Good work, thank you.
Oh, there's one. We've got time for one more question.
Vivian.
Thanks, Di. Great presentation. I have a question about the amount of exercise. Is something better than nothing, or is there just an amount that you have to do to make a difference?
Something is definitely better than nothing. So the recommendations are to take physical activity. The guidelines at the moment are relatively open, because it's talking about sort of 150 minutes of aerobic exercise per week and 2 resistance training sessions per week. But I think it does have to be tailored, because obviously if you're losing weight, doing 150 minutes of aerobic exercise may not actually put any more sort of muscle back on you, whereas if you did some resistance training with good nutrition, you'd actually get that muscle back. So it does have to be tailored according to what the problem is, and that's why you need it prescribed by an exercise physiologist. ESS is producing an update of their guidelines as to recommendations. So it does depend on the problem that you have, because you don't want to be doing something that might actually detriment you.
Okay. Thank you very much, Di. I appreciate it. Thank you.